Um, Good morning, good afternoon, good evening to everyone. Welcome to today's LSE's online public events, wherever you are in the world. We have titled this online event as Impact of COVID-19 on Global Health, a comparative look at the African region. The event is being co-hosted by the LSE's Firoz Lalji Centre for Africa and LSE's Global Health Initiative. LSE Firoz Lalji Centre for Africa promotes independent academic research and teaching, open and issue-oriented debates, and evidence-based policymaking. The center connects social sciences disciplines and works in partnership with Africa to bring African voices to global debates. LSE Global Health Initiative, on the other hand, is an interdepartmental research platform that applies LSE's tradition of rigorous social science research to emerging global health challenges. So my name is Aduragbemi Banke Thomas. I am a research fellow at the LSE Health at the London School of Economics and Political Science. And I will be chairing these events and these discussions today. I am very pleased to be here to welcome our excellent panelists for today's event, and you would meet them as we go through our time today. We have Dr. Musoka Fowler from Liberia.
Hello.
We have Dr. Solomon Kamurari from Uganda, Dr. Helen Yifta from and Dr. Abe Seifu from Ethiopia. I thought for us to start, I would probably just, I thought it would be useful to give some context to our discussion today. Right, I just want to make sure I'm sharing my screen now. 1 second. Okay. Am I able to share my screen? Share. Okay. So just as some form of context to where we are with the pandemic. Well, you see from the slides that I'm sharing that up to today, and this was right this morning, there have been 382,652 cases that have been recorded in Africa. 9,657 of these have ended in death, sadly, unfortunately. But there have also been 182,569 recoveries thus far. However, when you look at sub-regional numbers, look at cases in Southern Africa compared to Northern Africa and to Western Africa, you see that actually there's a difference in profile. Southern Africa seems to have more cases, Northern Africa seems to have more deaths. Recoveries seem to be better in Southern Africa compared to Western and Northern Africa. But as this impact varies, so has the response varied. And as Africa kind of responds to the COVID-19 pandemic, countries have also shifted their public health agendas and funding to focus on outbreak preparedness and management. So today, we will be exploring issues around the impact of COVID-19 on global health. Particularly, we know that while there's been lots of interest that's been placed on the pandemic itself and how it's going to be managed, there has been minimal focus on the other parts of health systems. And many of these were the issues that we tagged as major concerns pre the pandemic. So that's what we want to talk about today. So 2 questions we want to be able to answer at the end of this session. One is, how has the outbreak impacted pre-existing health concerns, public health concerns? Number 2 is how have those responses differed regionally? Our panelists will discuss individual country policy responses, the impact of COVID on health services such as outpatient visits, vaccinations, skill-based attendance, and approaches to tackling excess mortality that have been used in various countries. In terms of format, and this is useful for those who have joined us, each panelist would have about 15 to 20 minutes to speak, and we would have 25 minutes afterwards to take questions. Please feel free to type your questions in the chat area. My colleagues would be able to pick up on this and address them. So without further ado, I would like to hand over to our first speaker, Dr. Solomon Kamurari. Dr. Solomon. I just unmuted. 1 second, you're still on mute. Yep, Dr. Solomon, over to you.
Okay. Thank you very much, Adura, for the wonderful context that you've given. Like he has shared, my name is Solomon Kamurari. I'm a medical doctor by background, and I work with the Uganda Health Alliance. The Uganda Health Alliance is a collaboration between the NHS and the Ministry of Health. And our role is to support the Ministry of Health in implementing its health sector plans, but as well to foster mutual collaboration in health sector development between the NHS and the Ministry of Health Uganda. I'll go straight to give some context of what is happening in Uganda. As Adura has shared, the first case of the corona was reported in Africa on 14th Feb. At that, Uganda had already put in place a national task force by 28th January, intensified surveillance at points of entry, and intensified risk communication, public awareness, prepared isolation centers and quarantine centers, and identified treatment centers. So these systems to be put in place followed lessons learned from the Ebola outbreak in 2000, where follow-up was made and systems put in place from national level to community level. So that helped a lot that Uganda was already ready by the time the first case was announced in Africa. By 18th March, there was no case in Uganda confirmed, but still the country went ahead to close education institutions that have over 15 million Ugandans. All forms of public gatherings were closed, and individuals traveling from high-risk countries were quarantined, and SOPs put in place for all settings, including workplaces, including health facilities, and all sorts of public places. So that was on 18th March. On 21st March, we confirmed our first case in Uganda. Why I am mentioning this is that the case was from Dubai, which was not among the high-risk countries at the time. As you're aware, World Health Organization published a list of high-risk countries where travelers from these countries were quarantined and particular attention paid to. But this first case was not coming from those countries and was coming from Dubai, where a number of Ugandans live and provide domestic labor and do all sorts of work there. And a number of them had already entered into the country. So immediately the country prohibited incoming travels, inbound travels coming to Uganda, except cargo, and stopped public transport. So again, the active surveillance systems went ahead, and tracking down of cases, tracking down of contacts was intensified, because as I mentioned earlier, the case was not coming from one of the high-risk countries that had been put, and yet was coming from one of the countries that was not so high on the risk radar. By 31st March, we had 44 confirmed cases. And on April 1st, we had our first phase of the lockdown, what we now is popularly called the lockdown. And this was aimed at breaking risk transmission, but also enabling the health system to put in place measures that can contain the progress of the pandemic, but also to carry out active surveillance. So that went on for the whole of April, and by the end of April, we had 83 confirmed cases. The lockdown continued, and measures to loosen it were communicated by 26th May, and gradually the lockdown was a bit loosened. By 31st May, we had 417 confirmed cases as measures went ahead to sort of loosen the lockdown, but also maintaining some of the restrictions that could increase the rate of transmission, as you can see by the trends. So currently, I don't want to dwell much on the statistics, but currently in Uganda, as of 28th June, we have 870 confirmed cases. We have 808 recoveries, and 190 cases are so far in admission. There are no deaths so far. You might notice some disparities that some of the cases might be higher than the confirmed cases. It's because, according to the current guidelines, when you confirm a case that is from foreigners, and you're hosting it in your country, you include it in your total number of cases. So currently, Uganda is having a number of cases that are from other countries who are predominantly truck drivers. And you are, as you are aware, Uganda is one of the largest hosts of refugees on the continent. So there are a number of those who are refugees from other countries. So in summary, what has been our approach in addressing and mitigating the effects of the pandemic? As I mentioned earlier, we learned from the previous outbreaks, especially the Ebola outbreak, to put in place public health systems that are able to address any outbreak from national to village level. So there was country level coordination, planning and monitoring. There was risk communication and community engagement at every point of the community. There was active surveillance. As I mentioned earlier, cases that had come from countries that were not on the high risk categories had already gotten into the community. So there was there was an active phase of surveillance, which continues up to now. Rapid response teams were put in place, and surveillance was also intensified at points of entry. Uganda has quite a porous border and shares borders with so many countries in the East African region. So and the borders are porous because individuals cross from either border. So there was intensified surveillance at the border points. As the pandemic rolled in Uganda, we had a challenge of truck drivers, and that was also addressed by putting in place border testing points. Mobile laboratories were moved to the various border points. There was the aspect of case management. Initially, there were designated facilities for case management within the capital, Kampala, and the neighboring Entebbe district, which is just at the airport. But then case management services were rolled out during the period of the lockdown. It enabled the Ministry of Health to roll out these services to the different regions of the country. Currently, the health system in Uganda is a referral system where every region has a regional referral hospital that provides specialized services at a regional level and oversees a population of over 1 million people. So these services were scaled out to the various points in the regional referral hospitals. And then, of course, mobilization of operational support and logistics to go in the different regions. There was also, as you're aware, the lockdown came with other effects where individuals were locked up in their homes, they couldn't access food. So there was also an aspect of social support where the government had to distribute food items and in certain instances, non-food items. So that is the brief background about the current situation in Uganda, how we're able to respond, building on the systems that were put in place from lessons on other outbreaks. The aspect of discussion today is about how has the outbreak affected the other health services. So to start with that, the pandemic and measures to mitigate the pandemic has severely disrupted health services at all levels. But when you look at the responses, in all countries actually, it has stretched the health system at all pillars of the health system. I will just go through the various pillars of the health system before we look at the delivery of services. For example, in the health financing, a lot of areas had to be neglected, so that budgets have to be mobilized to put systems in place to address the needs for the outbreak. So it is obvious that several areas have been, sort of suffocated because finances had to be mobilized and priority taken to COVID. In terms of human resource, there were several ways in which this was impacted. Health workers who were into other routine services had to be mobilized to offer services that are focused on COVID in certain areas. For certain hospitals that were designated as treatment centers, such hospitals, for example, the Entebbe Regional Referral Hospital, had to specifically take care of the COVID-19 patients. So the other services had to suffer because health workers had been mobilized to offer care to COVID patients. Health information systems, the Uganda uses the HMIS reporting system where diseases are tracked and reported to the central system. The completion rate before was around 98%, but anecdotal data, although it hasn't been analyzed, shows that there's a massive decline in the reporting system, which affects trends of other disease burdens. Then essential medical products and technologies, as you're aware, as countries locked down, most of our products are actually imported. So 70% of our essential medicines are imported from other countries. So these were not readily available, and some of the supplies were hoarded, rather countries wanted them, so they couldn't export them due to certain measures that were put in place. So at a system level, all areas were affected, including leadership and governance. Like I told you, Uganda's health system is decentralized. So at a district level, the health system is sort of autonomous, but reports to the Ministry of Health. So leaders at all levels had to focus on addressing the COVID pandemic, and all other areas were in a blind spot. Our discussion today focuses on routine services. So I will speak about at hospital level. We held a discussion about a week ago about the mental health services, for instance, and how the COVID pandemic has affected them. Some of the sharing from the psychiatrists were that, first of all, the burden of mental health disorders has increased in the population because of the anxiety, because of the adverse living conditions, because of the different anxieties that come with the malady. So that has increased the burden in the population. But these services, until of late when they are being loosened back to normal, the services were not available. Even the health workers themselves were afraid to provide those services because patients were of unknown risk profile. With the lockdown, there was limited public transportation, and the ambulance service in Uganda is very, very low. So patients could not travel, and those who are reporting now report with either complications or with severity of disease. So you could see that this mirrors in all other services. The Uganda delivers what we call the minimum package, where certain services are considered very essential to the population, like maternal health, child health, mental health is one of them, and NCDs. So at the time, in the middle of the lockdown, when cases were rising, most hospitals were providing emergency services only. So these other services were neglected. And again, individuals, of those emergency services, individuals had challenges to travel from their communities to access hospitals. So because there was locked public transportation. So that really affected, one, the patients themselves, but also there were no services at that time. So as the lockdown is being loosened, as services are being returned to, we see there are reported complications, there are reported surge in worsening chronic conditions. The thing that I can't live without talking about are HIV and related illnesses. At one time, HIV patients had challenges with getting ART refill. ART refill is the medication for that is antiretroviral therapy. So there was a challenge in getting refills at the various refill points. So that, of course, affects the disease progress, because for HIV patients, really, they have to be on continued therapy. That was also the case for other chronic illnesses where patients required routine refill. For emergency services like maternal health, other child health conditions, there was effect on linkage of community to the health facilities, first of all, but also the health facility, there were challenges because, like I told you earlier, in the pillars of the health system where we looked at human resource, most health workers were mobilized to take care of other conditions, but also there was fear among health workers to handle patients because at the time, some of them did not have personal protective gear, and the anxiety still continues. In terms of auxiliary services like basic diagnostic imaging, laboratory services, blood bank services, there were major gaps. For instance, there were a number of shortages in blood services because, first of all, the donors were locked up. Most of these donors are school children. They're already at home. So this has really created a huge gap as services start opening up. That is at hospital level. I might not explore all the various services, but they mirror what is happening in other services. The challenges of patients accessing care, certain services not being available at the facilities, shifting of priorities to take care of COVID patients and neglecting certain services. So there is already a huge gap to fill by the time we start opening up for other services start taking place at hospital level. At primary healthcare level, there were certain challenges. For instance, the top 3 leading risk factors for disease are alcohol abuse, childhood underweight, and the top 2 are alcohol abuse and childhood underweight. I'll talk about alcohol abuse. With the lockdown, there was a lot of stress on individuals. So that really caused a surge in alcohol abuse. This is anecdotal information from the discussion we held with the various psychiatrists in the country. So a lot of risk communication about all this went down because primary healthcare programs on prevention and community outreaches were stopped. The other direct effects of the measures to mitigate the pandemic are also impacted on the primary health of individuals. For instance, with populations not working, there was a shortage of food, and that is expected, of course, to impact on the children and other vulnerable populations. So at primary healthcare level, really there was measures were affected that would rather address community interventions, look at social protection, look at health promotion in general. So in all aspects, the pandemic has either directly affected or measures to mitigate the progress of the pandemic have disrupted health services from hospital level to community level. The other question was how is the health system trying to bring back these essential services, whether these services back. The Ministry of Health is opening up these services in a gradual manner. But of course, like I mentioned earlier, there is need to sensitize health workers because all of them, most of them are anxious about handling patients who are of known risk profile. The health workers, the patients themselves are afraid to go to hospitals, especially those that are designated as treatment centers. So they would rather stay home or visit a nearby facility, but not to go to the appropriate level of care. As I mentioned earlier, the Uganda health system is a referral system. So the care that you would receive at the district hospital would be different from the care that you would receive at a very lower health facility. But patients would fear to go to centers that are designated as treatment centers. So currently, Ministry of Health and partners are working with different health workers across the country to sensitize them, to train them on how, one, they can return some of the services, but also have a high index suspicion, continue active surveillance to make sure that some of these services are being provided. The other thing that health workers have been finding challenges with is availability of personal protection equipment. So currently, Ministry of Health is putting measures to make sure that the various facilities that return other services have appropriate PPEs for protection as issued by guidelines from Ministry of Health. For the communities, the country and the Ministry of Health has put in place measures to widely communicate to communities on how, first of all, allaying their fears, but also mobilizing them to reduce some of the anxieties that come with expectation to get the virus and that kind of thing. So that is expected to sort of desensitize individuals who are fearing to go to the facilities. At facility level, like I informed you, there were gaps in terms of supply, in terms of setting up these actual services. So Ministry of Health is putting in place measures to see that as other services return, some of the missing essential supplies are being supplied through the supply system. And of course, that is structural. At the top of the pyramid, there's mobilization of local factories to produce some of the missing supplies that would rather be imported. So a number of factories have now shifted priorities to produce these supplies to make sure at least facilities are adequately supplied as services return. So there are a number of measures that are going in place to set up this service at clinical level, at administrative level, to make sure that as services gradually return, the routine services, people find supplies there. Of course, the linkage between facilities and communities, as I informed you, the ambulance system in the country is not that robust. So measures to open up public transport are taking place and have been opened, but also although vehicles and other means of public transport are taking half capacity, enable movement of individuals that include patient populations to access these services. At community level, still mass gatherings are currently prohibited. So the country is using multimedia to pass on public health information, to do health promotion in other services. But still, of course, there are challenges there in terms of access to this information that the Ministry of Health is trying to put measures in place. Mobilization is being done up to community level to communicate some of the health messages that will be going on. But of course, there are still challenges on how individuals can be accessed since the initial styles of risk communication and health promotion were in mass gatherings. So currently, the only method is to use multimedia as we see how things will return to normal. I see my time is fast spent, but I would say the country is Uganda is opening up gradually, and some of these routine health services that were initially suspended are coming back. But what we are noticing from anecdotal data and from experiences of clinicians is that patients who are reporting there's an increased burden of these conditions in the population. Those who had chronic conditions, some of them have worsened because they didn't receive appropriate care during the lockdown. At facility level, because priorities had shifted, there are challenges in supplies and provision of these services. But the silver lining is that the health sector and the government are putting measures in place to address these challenges. I'll stop there for the interest of time. Thank you very much.
Dr. Kamarari, thank you so very much for your detailed presentation. I'm glad with where you ended, which is that there is a silver lining, and we will be discussing that in detail when we get to the question and answer session. Thank you very much. Quickly, we would move on to Dr. Fowler from Liberia. If your connection is great now, Dr. Fowler, please can you come up? While he's doing that, I would give a quick introduction about Dr. Fowler. Is he on now? Just let me confirm. Nope, I think it's not. Yes, so Dr. Fowler is struggling with his connection, I believe. If it's not on, I would like us to move on to Dr. Yifta, if you're ready, Dr. Yifta, and Dr. Abe from Ethiopia. Dr. Helen, and I can start with an introduction to the group there. Dr. Helen, please could you just turn on your video and connect? So Dr. Helen Yifta is an assistant professor of medicine at the Department of Internal Medicine. Yeah, okay, I can see you're connected now, perfect. Yes, so I was saying that she's an assistant professor of medicine at the Department of Internal Medicine, School of Medicine at Addis Ababa University. She's a consultant internist and endocrinologist at the Tiko Ambassa Hospital. And Dr. Abe Seifu is the chair of the Department of Reproductive, Family and Population Health in the School of Public Health at Addis Ababa University. He's a public health specialist with over 10 years of experience in design, implementation, and evaluation of maternal and newborn health programs, quality improvement interventions, and health systems strengthening. Over to you then.
Thank you so much. Good afternoon, good morning, good evening, everyone. So I will co-facilitate this presentation with Dr. Helen and go through a couple of slides first, and then we'll hand over to Dr. Helen. Okay. So the content of our presentation will be We'll go through a bit of background, then we'll talk about Ethiopia's COVID response, a very high level overview, and then we'll share also some observations that were done in Addis Ababa regarding the different practices, recommended practices. And then we'll see the evolution of Ethiopia's COVID-19 cases for the 3 months following the first case report. And then we'll look at the impact of this COVID-19 on health services before we conclude. So to give you a background, Ethiopia has more than 115 million population, the second biggest country in Africa. And more 80% of the population lives in rural area. There are a number of indicators that we can discuss, but for this purpose, we want to share 2 important indicators. Maternal mortality ratio stood at 412 in 2016 DHS report out of 100,000 live births, and under 5 mortality rate at 55 per 1,000 live births in the recent mini EDHS report last year. Ethiopia has a double burden of non-communicable disease and injuries and infectious diseases. So regarding the health system, Ethiopia has in the last couple of decades managed to expand healthcare access to the population, mainly through expanding primary health care services around the country. We are proud of the health extension program that has enabled families in the village to access basic health services and health promotion services. But the health system is not ready. Remains very fragile to sustain a hit by epidemic like COVID-19. So prevention and containment of the epidemic remains the best strategy for our health system. Regarding some of the response actions that Ethiopia took, so the first case was reported in Ethiopia on March 13, but the country has started preparation to respond to the pandemic, early around mid-January, by starting fever screening at the Bole International Airport, one of the busiest airports in Africa. And then, following close to, end of February, a ministerial committee was established by the Prime Minister, which reports directly to him. And there are a number of committees and groups that work under this and within the Ministry of Health. And then other important, measures were, for example, the state of emergency that was issued on April 10, that resulted in restriction of travel, cease of transport, physical distance, physical contact, and public gathering. And there is also universal face mask use that was enforced later in May. And these are some of the observations that were done regarding respiratory and hand washing hygiene or personal hygiene. So our staffs from College of Health Sciences, School of Public Health here at Addis Ababa University did observation of different service delivery points and selected places in the town and observed directly the practice of people regarding face mask use and hand washing practice and physical distancing practice. And as you may see, the face mask use, which was also facilitated by the universal face mask enforced later in May, showed a steady increase, but hand washing practice and also physical distancing in Addis was not that much practiced. It remains moderate. And regarding the evolution of COVID-19 cases, we have to see this chart with the context of the expansion of the COVID-19 testing in the country. So the testing capacity has expanded over time, but the number of cases identified, for example, in the first month since the report of the first case was about 2.3 on average. It increased to 6.6 in the second month and to 86 in daily. This is daily case report in the third month, and the number is picking still. And so as of June 14, we had about 4,700 cases and 72 deaths. As of yesterday, that number of cases increased to 5,600 and the deaths to 98. And most of these cases are concentrated in Addis Ababa, and most of the positive cases are male. So we need to do more, studies to understand why males are particularly affected, but there are some, speculation on that. So obviously Addis Ababa being the link with the external world and, a lot of travelers coming from within the country. So it remained a hotspot in terms of COVID-19 expansion. So I will stop here and hand over to Dr. Helen to take us through the remaining slides.
Thank you, Abi. So next to how Ethiopia responded to the COVID pandemic, as it happened across the world, essential services were affected because all resources and healthcare workforce was geared to COVID response. And cognizant of this, the Ministry of Health published an implementation guide for non-COVID-19 essential services, which has 10 sections and also identified the priority essential services, the governance and leadership, the referral mechanisms, monitoring and evaluation for essential services, to how to do essential services in Addis Ababa, in the regions, and how task forces would be established at the ministerial level, but also going to the regional health bureaus and each facilities to reinitiate and strengthen the essential services. So what happened was most of the healthcare facilities were either closed, some were assigned for COVID, quarantining COVID positive patients, or as quarantine facilities for people who were coming from abroad, or patients who were identified as close contacts of COVID positive patients. So trying to restart the essential services and also ensure continuity of services at the different health settings. And in order to look into how the COVID-19 pandemic may have affected or impacted the essential health services, we took the WHO's health system building blocks, and we will look each in terms of how the COVID response or the COVID pandemic has affected essential services in Ethiopia. So when we start with the leadership and governance, when we say there was leadership change and uncertainty, particularly in Ethiopia, there was change of the ministers, and also when the pandemic came, there was established ministerial level committee which would overlook the pandemic, and also at the ministry level, the state ministers were leading the COVID response. So this leadership change at the ministerial level but also at each institution and regional health bureaus has created uncertainties in terms of continuity of essential cares. There was shift of focus and also virtual engagements in terms of meetings or on-site supervisions. So especially when there was travel restriction and people could not go to health facilities to do supervisions, this would create, this will affect the continuity of services and also monitoring and evaluation. The other thing is virtual engagements are not our culture. And when meetings change to virtual engagements, then it would create problems in communications. The other thing is financing. So most of the healthcare programs are funded by external aid, and we anticipate there will be a decrease in external aid because of economic losses due to COVID-19. It is forecasted that the national GDP would also decrease, so this would also affect the healthcare financing. Because of the COVID-19 response, many businesses are closed in Ethiopia. 1/3 of families are treated out of pocket, and when the income of families decreases, again, healthcare financing would be affected, and the diversion of other health program resources to COVID-19, especially procurement of personal protective equipments, would affect the financing of the essential health services. The other is access to essential medicine. So again, because of the shift of production of commodities to personal protective equipment, we anticipate there would be decrease in production of essential commodities. There would be financial problem to procure commodities, and also because of, again, travel restrictions, we import most of our essential medicine, so that would also affect the access to essential medicine to ensure continuity of essential services. The other is the health information systems. So now we see that the COVID-19 information system is vertical, and we see daily reports of COVID-19 information, but we are overlooking the essential service reports, and it's not integrated with the essential health service. So the vertical COVID information system is good to track the COVID pandemic, but it may affect the reporting of essential services. Again, there is diversion of response in terms of the HMIS staff and infrastructure for HMIS. The culture of rapid analysis and use of data for decision might have changed positively in terms of, I was saying, we are seeing daily reports of COVID-19 pandemic, and we are using more data to guide our decisions in terms of developing guidelines or changing directives, for example, for quarantine, or what do we do with COVID positive patients. Then that's a good impact of COVID-19 for health information systems. And digitalization, again, we see reporting is now being done on social media and the mass media, and that's also a good experience in terms of digitalizing health information systems. The health workforce. So again, there is a shift of providers to COVID response. So most of the essential workers for the essential health services are being shifted to COVID-19 treatment centers, to emergency operating centers, and this will affect the continuity of care. There is increased staff absenteeism, either due to infection by COVID-19 or being quarantined by being identified as a close contact of a positive patient. And there is increased fear, stress, and psychological symptoms of staff, which would increase absenteeism from healthcare settings. And when we go to, especially to the rural setting, most of the essential services are run by our health extension workers, and home visits by health extension workers is being affected, and that would also be a problem in continuing essential services, especially in the rural setting. When we go to the service delivery, we have observed that there is decreased care seeking from patients and the community. And we have also seen that there is decrease in emergency obstetric and neonatal care services. There was a decrease in blood donation, and you may have seen the ministry was calling for volunteers to donate blood, and that there were a lot of facilities which were closed, and some were changed to COVID quarantine or treatment centers, and that has affected the service delivery of essential services. And patients and also healthcare workers have heightened fear of nosocomial infection, again, which would affect in terms of service delivery. And again, because of shift of the workforce, there is decrease on-site mentorship and support, which would also affect service delivery. And in terms of the infection prevention and control, we feel that there is a mixed effect in terms of there was a campaign in increasing awareness of the community in terms of infection prevention. And as I have seen, the use of masks for respiratory hygiene, the hand washing habit of our community has increased, and that is good in terms of community and also health worker infection prevention culture. But when we look at the personal protective equipment use, then there was a decision to shift PPE to COVID centers, and there was not enough PPE supplied to non-COVID centers, and that has affected the service delivery at non-COVID centers. And just to give you a look into how the COVID pandemic may have affected service utilization, this is a service utilization data from the Tukurambesa Specialized Hospital, and it is the biggest referral hospital in Ethiopia. It gives service to close to more than 500,000 patients in a year. And we compared the 3 years, 2018, 19, and 2020, January to June. And you can see in general, there is a trend, there is a decreasing trend in 2020, January to June in terms of all services except maternal services. So delivery actually increased in our hospital in 2020, and this is mainly because other hospitals were closed, and our hospital was one of the few hospitals which continued to give essential services in the COVID pandemic, and also because laboring mothers could not stay at home, they have to come to the health services in Addis Ababa. So in conclusion, Ethiopia's response to COVID-19 appears to start early, and government has taken several measures at different levels. The focus, resource, and efforts are being directed at prevention and containment of COVID-19, and there are early signs that the vertical approach to COVID-19 may be impacting essential routine care. And with this, we thank you very much for your attention.
Thank you very much, Dr. Yifta and Dr. Abe. That was very, very insightful presentation. I particularly loved that chart that clearly showed the difference in service utilization over the years, and I'm sure we would have questions focusing on that when we get to the Q&A session. I would like to give one more trial to Dr. Fowler. I know he's trying very hard to connect to this meeting. Dr. Fowler from Liberia. Dr. Fowler, are you able to connect? You don't have to use your video if the internet speed is poor at your end. Are you able to just speak to this event? Just give Dr. Fowler a few minutes, or more like say. Okay. Okay. I think we would have to move on then. And maybe I'll just spend some time coming back to some of the presentations the two presentations that we've had thus far, and we would have to skip the presentation from Liberia. to the Ethiopia team, I would like to come back to you on a few questions that I had, and maybe just to push, and maybe not necessarily the questions, but really to just kind of get more insight in some of the points that you had raised. You did mention that there had been a shift in maternal newborn health service provision to this COVID-19 response. Are you able to provide more details? Specifically, how has this happened? What has, which staff are being moved? And how are maternal newborn health professionals able to provide essentially infectious disease control services?
Thank you. Can you hear us?
Yes, we can. Yes, we can.
So thank you for that question. So one note I think we want to take is that, we have not talked about it, but since the data is held from the health information management system, there are some, gaps in terms of quality. Although the overall trend remains to be the same, it may not reflect exactly what happened in the facilities. But I think in terms of, maternal health services and all services for that matter, immediately after the report of the first case, in the first 2 weeks, there was, large decrease or decline of the service uptake. We were afraid for the providers. And,
hello?
yes.
Just in case.
Sorry about that. I think Dr. Fowler is now connecting.
Yeah, I came back. Sorry, I had to run to see the president briefly. I'm sorry. When
Okay.
the president called, you have to listen.
Okay, it's okay. Dr. Fowler, would you be able to present now? Because we're already
Yes, I can. I just completed my meeting with His Excellency. I can talk now. Yeah.
Okay, 1 second. 1 second, so we can move over to you. Dr. Bay, is that okay? Can we just move and let's just, since Dr. Fowler appears to be on the move, let's just have his presentation and then we'll come back to the questions, okay? Is that okay? Perfect. Okay. Dr. Fowler, over to you now.
Thank you very much. I know you asked the primary question, how is COVID affecting the health system? But it's good to have a context of the of our response. A very classical example of like Uganda, Ebola, the 2014 Ebola outbreak helped Liberia prepare for COVID in a lot of ways. As far back as January 22nd, we approached the president, His Excellency, that the growing cases of corona in Wuhan warrant us activating enhanced airport screening. And so we did that. Again, one of the strengths of Ebola is it helps us to build the infrastructure. Prior to Ebola, we really did not have infrastructure for surveillance system. But based on the lesson from Ebola, we're able to, first of all, develop a National Public Health Institute, whose job was to do early warning and surveillance system. And I head the Public Health Institute right now as the Director General. And so based on our infrastructure for early warning and surveillance system, we did a risk profile and realized that our greatest risks will be at the airport, the international airport. And so around the 25th of January, we instituted enhanced airport screening with health questionnaire, hand washing, and tracking of all visitors from China. Eventually, when the outbreak spread to Europe, we changed our advisory and we became the first country to institute institutional quarantine. We did institutional quarantine because it became difficult to track people that were traveling, especially Liberians from China. We also used our lesson from Ebola to develop the political will. We established the President Advisory Commission on COVID, headed by the President. and the technical committee of all key ministers, including the Minister of Defense. We converted the military hospital into an Ebola treatment unit long before we had our first case. We also activated the incident management system. This is one of the things we got from Ebola. So regularly we have what we call the epidemic preparedness and response meeting every week with our partners. It is flexible such that when there is an outbreak, we shift from preparedness to incident management system. At the time, I became the incident manager responsible for coordinating the response. Our first case was on March the 16th. He was an official of government who went to Europe for a workshop. What also we did, following the model from WHO, we developed the Vero pillows. We had a coordination pillows, psychosocial pillow, RISCOM, surveillance, contact tracing. But to summarize, one of the key things that help us is that most of the key actors in the preparedness phase and the response were people who had gone through the Ebola outbreak. So they were experienced in contact tracing, they were experienced in managing outbreaks. And since after the outbreak, we had responded to over 200 different events from measles to many. As a result of that, we're able to build a system. Another key legacy of Ebola was the laboratory system, the National Reference Lab. When Ebola started, we had to ship our specimen laboratory system to test for viral hemorrhagic fever and Lassa. As a result, once coronavirus became a global threat, we did a rapid risk assessment to determine where we needed to do, whether our lab was capable of testing for coronavirus. And yes, we realized that we had the same platform. What we needed were the primers and the probe. We sent one of our guys to Senegal at the Institut Pasteur for rapid training. He got a quick pressure training, and we're able to get the primers and probe from WHO through Germany. And so when our first case started on March the 15th, we collected the specimen. On the morning of March the 16th, we got our first confirmed case. The case was isolated immediately at the 14 military hospital, and the contacts were kept in hotels and other institutions for quarantine. Where do we stand today? Fast forward. As of this morning, we have 725 cases. Liberia has 725 cases. 82.7% of those cases are in the capital. Out of the 15 counties, 12 of the counties are responding. We have had 5 deaths in our treatment unit and a little over 50% recovery rate. So this is where we stand right now. In terms of overall response, we've now concluded that the use of masks and the use of hand washing massively used by communities has to be the way to go. What we have seen a shift in behavior between COVID-19 and Ebola is that as far back as January, we instituted the no handshake and the hand washing. The Liberians were able to quickly readjust to no handshake and hand washing based on their experience.
Okay, I think. Dr. Fowler? Okay.
Hello, it's the
Yes,
issue of masks working, and the issue of social distancing is still a challenge. So I've just given you a summary of the health system, the political will. It's an all-government approach. All institutions and ministries and agencies are involved in the response to COVID. We can say we are a bit of an outlier. I'm going to start pulling. We are a bit of an outlier in terms of the total number of cases. Most of our neighbors in the sub-region, like Sierra Leone, has around 1,700 cases, Guinea is around 6,000. Ivory Coast is around 6,000. But we still have not reached 1,000. And we are testing, we are ramped up our testing. We have listed of different innovations that we developed drive-through testing based on our experience, what we read from South Korea. We now have centers where people can drive through and get tested voluntarily. So what is the effect of COVID-19 on the health system? I will probably give you some numbers and you have a good appreciation. We have compared this period to last year based on the HMIS. We have seen that attendance at health facility has dropped by 23%. There is a 23% drop in health facility attendance. We have also established that on-fire treatment for malaria has dropped by 34%. Above-fire treatment for malaria has dropped by 35%. 35% of the children are not immunized this year compared to the same period last year. We also saw that 10% of those needed to be tested for HIV, AIDS, and receive drugs are not receiving it. We see that there is a decrease, 20% of new cases of diabetes mellitus, which implies that for the same period last year to this year, all of the essential services, including malaria, including immunization, has dropped. So these numbers by themselves indicate that we see that there is a decrease in health services. I have done some extensive work to establish some of the reasons. What we have realized on the demand side is that the patients are afraid to go to the hospital. Many of them have the wrong notion that if they go to the hospital and they present with symptoms like fever, which is common for malaria, they will be tested for COVID-19 and isolated. And so we see that the health system has a burden. Let me begin by discussing financing. West Africa or countries that were hit by Ebola had a mechanism from the World Bank called the REDICI. And when COVID-19 struck, the World Bank was able to rapidly reprogram the money. Liberia, for instance, had $15 million for surveillance for 5 years. So what the World Bank did was to accelerate that funding so that it could be shifted to COVID-19 activities. Even though it is not adequate, but it has been the readiest source of income for the country to finance COVID-19 without necessarily already going into the struggling health system. The government have had to finance it. Most of it also have had to find some financing. Like initially we needed $3 million to run the institutional quarantine and the response, and the bulk of the money came from the government. Obviously, that means it's affecting the regular health system, procurement of drugs and distribution. Supply chain, the government has tried to supply drugs in the regular health system, but there's also one good thing from Ebola. Most of the PPE that we are using now were kept after Ebola in what we call forward logistic bases. There were 5 logistic hubs created across the country after Ebola with PPE and supplies. And so what we did at the Public Health Institute was to quickly go through those supplies and supply for response and healthcare workers. That does not necessarily mean that we are not seeing increasing health worker infection, but the Ebola also, the residual logistics help us to move that. And so there is a parallel supply chain system, the one from Ebola and the new ones that we are creating for the response and also for the regular health system. Now that 12 of our 15 counties have cases. In terms of information sharing technology, one of the lessons we've learned from Ebola was to keep surveillance, passive and active surveillance separated. And so we still have the active surveillance being used for COVID-19, and the passive surveillance through the district health officers are still collecting data for our HMIS. And so as I indicated to you, we have been able to compare health service delivery from January to current compared to last year because we have data still flowing. Health workforce is a challenge because some of the health workforce have to move to support the COVID response. And that is causing some problem for us. The regular health workforce are also asking for hazard pay, because right now those assigned to the regular health system, hospitals, we see that they are among the greatest risks for infection, and so they are demanding for hazard pay. But in the current response, there is no funding for hazard pay for regular health workers. The hazard pay is for those who are involved in the direct response. That is creating such a troubling scenario with sometimes threat for demonstration from those in the regular health services. And so overall, that's where the health system sits for Liberia right now. Low attendance, low service utilization. We think that we need to do more work in risk communication. We need to do more work in the masks, in mask ownership and mask utilization and hand washing. One thing we're trying to go back, even as I was briefing the president this morning, is that we need to give the response to the communities, because it's cost effective if the communities own it. And so we are working hard to shift the model from the bottom up approach. And so I think you see from the data and my brief summary that we have some blessing, we have some buffering effect from the investment that was done from Ebola, but that still does not negate the fact that there are challenges in supply chain, there are challenges in financing. We have closed the border, no flights are coming in country. And so I just want to summarize that we have a dual edge. I mean, blessings from Ebola, but yet the health system still continuing to struggle in other areas. Thank you very much.
Dr. Fowler, we are so privileged to have you and to get your insights. I think you are the closest we have gotten to the government, and it's so lovely to be able to hear your thoughts. That was very, very insightful, and I'm sure you're going to have questions to address. We will be putting the questions together right now. I have a few questions already here to the panelists. Some have been directed to specific people. I will try to put them together. But I also know my colleagues will be working on trying to get the questions from Facebook because we're also live on Facebook. So thank you very much for that. In the meantime, I would ask the questions that I have. Dr. Helen, no, Dr. Abe, you were the one responding to a previous question. Did you just want to wrap that up quickly on how maternal and newborn health workers were able to shift into COVID-19 response?
Yeah, so, I mean, this is in general, as we have, few health workers in the health system, so they are mobilized to respond to the pandemic when there is a heightened fear from everywhere about addressing the COVID-19 pandemic. But in our hospital specifically, I was saying earlier, because of our, we established emergency operations center that had, several meetings and made decision to keep the maternal and newborn health services running despite the pandemic, scenario. A lot of mothers and newborns came to receive care. So that was what I was starting.
All right. Thank you very much. There is this question, and this is something that your presentation, I think this came across board in all presentations, that there's been a shift of focus on where health services are provided. And for the reason of services being pressed, there's been a need to have to change hospitals that were designated for specific purposes to provide care for COVID-19 patients. I'm aware that in some parts of Africa, Nigeria, Lagos, for example, there was a construction of new sets of buildings, designation of new areas. I think Dr. Fowler kind of mentioned that also as places to provide care for patients with COVID-19. What are your thoughts around this? Should existing facilities and structures that pre-pandemic were already stretched, they were not sufficient for cases being managed pre-pandemic, should they be used in such instances as places of care when pandemics happen, or should we be exploring new other sites to provide care? Should we Solomon, do you want to go first before we move to Dr. Fowler?
Yes, thanks, Adura. Like you put very well, these facilities were already stretched by the time they were designated as COVID centers. So the evidence is that it is challenging to overburden these facilities. So what is happening in Uganda is that we are using some of the innovations that are in place. For example, currently we have an innovation called the EP tent, where a new field hospital can be mobilized and put in place in all these regions, separate from the facilities that provide continuing services. The military hospital has set up, for example, an 100-bed capacity using the EP tent to address challenges in such areas. The other approach that we are taking is similar to what is happening in the UK, is that in case the pandemic rolls and we have overwhelming numbers, we are instead looking at converting, for example, the National Stadium into a treatment center. So the approaches show that it is not a good idea to overburden these hospitals that would rather provide the other services. So we're looking at those innovations. Thank you.
Gotcha. Thank you very much for that. It's interesting that we now use football pitches for hospitals. Dr. Fowler, do you have anything to say to that? Designating hotels as treatment centers in Liberia?
Hello?
Yes, hello.
So the hotel was used as quarantine center. Hotels were used as quarantine center, and we converted the military hospital into the treatment center. So there are three categories of treatment center. You say there is one for confirmed cases at the military hospital with all red zone. We have a second hospital for suspected cases. And then we have the quarantine centers. We chose the hotels for quarantining. Yeah, so we had.
Okay.
Yeah, the hotel was used for quarantining, to quarantine high-risk contact and travelers. Yeah.
All right. Thank you. Let me go straight to the questions that we have, because I think we've now been able to pull them together. We have a question to the Ethiopia team from Sarawit Kasa. If I got your name properly, I'll do my best to do this well. Thanks for all the presentations. From the presentation by the Ethiopian team, it looks like other services have been affected due to COVID-19. This is true everywhere. What short-term and long-term plans or interventions are in place to increase uptake as well as quality of other services? That's the question.
Thank you, Adura, and also Sarawit. So as I was mentioning earlier, the Ministry of Health of Ethiopia published an implementation guide on how to continue essential services. So I was saying services, hospitals and health centers are designated as COVID treatment centers, and those who would run the essential health services. And in that guide, they have clearly outlined how we would continue or make sure the continuity of essential services in terms of which are the priority areas, how we are going, for example, in terms of non-communicable diseases, those already on treatment, how health facilities could reach them. Or if they cannot come to the health facilities, we have already some health facilities have set up phone clinics, or if they cannot, if they have to come in person and they cannot come, how we could link them to their nearby health facilities. So a lot of efforts are going on to ensure the continuity of essential health services. And we have a guide from the Ministry of Health how to implement it. And it is on the website of Ministry of Health, and you can refer to it, how Ethiopia is doing to continue essential services.
Right. Thank you very much. And I think that kind of links to the other question from Kebede Deribe, which was on what key measures should be taken to maintain essential health services for those who are in need. I guess that kind of addresses that also. Dr. Fowler, again, this is for you, right? I'm sorry I'm putting you on the spot, but you did mention slightly about Lassa fever diagnosis and how there was a shift to COVID-19 diagnosis. We've seen generally that there's been some pockets of outbreaks of Lassa fever around Africa in the middle of the pandemic. Do you think that some of those outbreaks, we have missed on them because we were focusing on COVID-19?
That's a very good question. We try to, because we have a surveillance system in place that does active surveillance, and the Lassa is one of our priority diseases. We've been testing a few Lassa cases we've gotten, they've been negative, and one of our Lassa heartbelt declared the end of Lassa. So we've been really worrying. It said that, and like the same question you have, we had to work in like a dual age, stay, do the diagnostic for COVID, but keep our eyes on Lassa.
Right.
But strangely enough, we've rarely seen either the disappearance or non-existence of Lassa in Liberia. And that's a key question we are asking ourselves. Is it really that we are missing it out? And our emphasis on COVID, the way we collect specimen for Lassa is different from COVID. COVID is the oral nasal swab. People are coming with fever and we are going first for COVID and not going back to Lassa. But this is strange for us. It is a hard question we're trying to ask and align our surveillance system to go after Lassa because we know the Lassa belts. So you are so right. It could likely be subsumed under COVID. And we're trying to activate that further. But that is so right. That's a key question that we have.
Right, Dr. Fowler, I think we got you there. That this is a key question that you are certainly still looking at, and I think it's a question for all health systems, particularly in Africa, that we don't miss out on some of these hidden outbreaks in the middle of the pandemic. But then, Dr. Yifta, this is to you now, your team in Ethiopia, because you had mentioned this also about there was reduced service utilization, even from the chart you had shown us. But how do we then disaggregate this? How do we know if some of this reduced service utilization was due to the fact that there was a lockdown in general, or due to the fact that people had some fear of COVID-19 and did not show up at the facilities?
I think it is both. For some of our patients, it was the fear of getting COVID-19 infection if they come to the health settings. They may acquire it in the hospital, or they use public transport, so they were afraid to use public transport to come to hospital seeking service. But for some of our patients, because they travel to visit our hospitals, then because of the lockdown, they could not come to the hospitals. So I would say both reasons are valid in terms of decreased utilization of health services by our patients.
Right. Okay. So I guess it might be difficult for us to know which of them was the primary reason, but it would be critical maybe for us to kind of be able to separate those things. We have a question for both the Liberia and Ethiopian presenters. It says, thank you for your excellent presentations. Both presenters mentioned establishment of high-level ministerial committees for COVID-19. In addition to being part of the process to build political will, how has multi-sectoral involvement influenced the impact of COVID-19 on the health systems and health services, financing, coordination, implementation? And I might add, this is a very fantastic question. I think this is pointing towards the role of the private sector, for example, in this COVID-19 response. Who wants to go first? Dr.
I can do this.
Okay.
I can take this because I probably will start for the last point, the private sector.
Yes.
One of the lessons we learned from Ebola was the power of the private sector. And so we engaged the private sector very early on to have them on board. And they really committed a lot of their resources. Like, for example, one of our cell phone companies gave us over 500 cell phones for contact tracing. You know, some of the large concession companies helped us to set up a treatment center for their concessions. And I made some trips recently. I saw that cases among the concession in the mining area had almost 100% contact tracing because they had a control environment. You know, we're trying to compare this concession era and also have the concession era. In terms of contact tracing, in terms of handling the cases, I realized that the concession era, because of their strong managerial commitment, were able to really do better job. But they've really helped us with example. We had 3 of our laboratory technologists studying in Nigeria at Redeemer University. We wanted to bring them in country. It's actually one of our concessionaires that chartered a special flight that brought them in country to help us. They had just shut down the airport in Liberia and Ghana and Nigeria. We had to arrange with a flight, a special flight, and was paid for by one of our private sector. So one key lesson we've learned from this is that engaging the private sector early on, and you know, having clearly defined roles and expectations can really work for you. And so the private health facilities have really worked with us. And then an all-government approach. What we have done is to outsource key response based on ministries. For example, on the port of entry, the immigration services, the National Immigration Services is responsible with playing a secondary role. When it comes to dead body management, we've given it to the Ministry of Internal Affairs. Since they need the chiefs and everybody, so the Ministry of Internal Affairs is responsible for dead body management. So if somebody dies, it is the local chief. And so based on the comparative advantage of each government institutions, they will play leadership role and the Ministry of Health will be secondary. And so we see by decentralizing and outsourcing some key response, it reduces the burden on the Ministry of Health to sort of focus on the regular health system.
Thank you very much for that, Dr. Fowler. I would have loved to pass it on to the Ethiopian team, but I think we have in the interest of time, I'm really keen for us to kind of walk through as many questions as possible. There's this very exciting question that I'm seeing here, and I'm not surprised it has come. Again, Dr. Fowler, it is to you. It says, thank you for your presentation, Dr. Fowler. My question is, in light of what many African countries would be facing with regards to the brain drain, what impact in particular has this had to the Liberian healthcare system and ratio of doctors to the population, and what measures have been put in place with this to plug the potential gaps, particularly with responding to a pandemic like we're experiencing right now?
Okay, thank you very much. 2 things I would say. Liberia started their own postgraduate program a few years ago. And so what has happened is that most of the doctors that are in the response are actually those in the postgraduate program. Most of those leading the response. A few of our doctors were sent to African country for training, Nigeria and Ghana, and some of them came back home. And they are very happy also to the, so most of the training was done in the sub-region. Our doctors are at home. So most of those doctors are now leading the clinical care for the patients. But also we have been able to link with the diaspora. Most of the diaspora, we've linked with them, they've been able to help us remotely, to support us remotely. In terms of clinical care, I think it has helped a lot that we can get to the diaspora and we can work with those in country. And I think one major blessing is that most of these key people were involved in Ebola. You know, Ebola may not have had a level of cases, but the intensity, the depth we saw, and you know, most of us were in different sectors. We came together to work with Ebola, and so we have been able to harness that. But also, as I said, the diaspora, the issue of virtual learning and virtual communication, and you know, having Zoom meetings, Zoom conferences, and picking on those in the diaspora, that has been one of the advantage. And you know, that has helped us. So either way, the brain drain may be negative, but the fact that we can reach them through Zoom conferences and get their input has been an advantage that we've gained.
Gotcha. Thank you very much, Dr. Fowler. What about, and I think this is going to go to Solomon, again, it's just piggybacking on that last question, and it's really about the role of community health workers, for example, to fill this gap, because if this is going to become our new normal and there's another outbreak coming up the next couple of who knows when, do you think community health workers can fill this gap, this human resource gap that we definitely are experiencing in Africa? Solomon?
Thank you, Adora and person who asked the question. Currently, the community health workers have been very essential in tracking contacts at the community level. As I mentioned, a number of individuals got into the community from Middle East. It was only the role of the community. It was really the community health workers that bridged the gap of identifying who came in the community, who is their contact, who is coming in recently. And when they put lockdowns, when there was a breach on the lockdowns, the people who were getting into communities from other areas, the community health workers were actively tracing them. So they have already played that role. In terms of sensitizing the community, they are doing that role once they are allowed to be part of the district health teams. So yes, the community health workers are playing a huge role in filling the gap of the last mile. That's what I can say about that.
Thank you very much. This question is the last one, and I'm looking at time right now. I know we need to wrap up. And it's a general question. I don't think it's specifically about the other gaps in the public health when it comes to COVID-19, but it says, what would be the main reason for the low infection and death rates in Africa generally as compared to other parts of the world? I would respond to this and say we are still trying to find out, okay? And I think we should just be careful about conjectures and trying to guess this. In wrapping up, I would say that was a very excellent presentation. Those were excellent presentations by our panelists. Thank you so much for your insights that you shared. I think it was interesting when Dr. Fowler said there were blessings of Ebola. Personally, I can't even believe we are saying that, but it's true. That experience has kind of helped African health systems to be better prepared for this, more than what had been modeled and expectations that had been predicted. Clearly, from what we've shown in this webinar, is that governments have been focusing so much on COVID-19 response, and there have been other priorities have been derailed. There have been reduced service utilization because of COVID-19 response, either from the governments themselves and the lockdown measures, or from concerns about it by the population. And there clearly, as we've shown also in the different presentations, that there are collateral effects of COVID-19. And many of them, I would argue, would only even begin to manifest in the next couple of months after the pandemic itself has ended. So clearly we need to maintain and probably even step up efforts in stemming the tide of COVID-19. But this is particularly important so that the suppression of what has been achieved so far compared to the modeled estimates remains so. But we need to also contextualize our responses to ensure that we do not ignore the other areas, the other priorities that we have identified even pre the pandemic. I'd say that as African health system, there's a need to look inwards. I know in one presentation we talked about, I think it was Ethiopia, we talked about that the funds are not coming in. Well, funds may not come in because other health systems are dealing with their own challenges themselves. I think Dr. Fowler also mentioned this also. But yes, we might need to look inwards and maximize our own internal sources of internally generated revenue, leveraging relationships with the private sector, for example. And in terms of human resources, where there is lack, maybe, just maybe, the cornerstone that has been rejected in community health workers would be the way for us to go. We thank all our attendees who have joined this online public event hosted by LSE Africa and LSE Global Health Initiative. We hope that you have learned something, and I personally learned a lot myself, and I'm so grateful, like I mentioned, to all the presenters. This recording is going to be available online, so you can listen to it again, and I believe that contact details would be shared also. So if you want to continue this conversation with the panelists or myself, please feel free to connect. Once again, thank you very much for joining us, and do have a wonderful rest of the day. And for those who are going to bed also in Australia who are signed in, enjoy your night. Thank you very much. Cheers. Bye.
Thank
Thank
you.
you.
Thank you very much. Bye. Thanks for everything.
Thank you. Bye.
Bye.